Hello, good afternoon, and welcome to the Melanoma Research Foundation Ask the Expert series presented by Castle Biosciences. My name is Liz Holland. I am the Senior Medical Science Liaison at Castle Biosciences, and we are truly grateful to the Melanoma Research Foundation in partnering with us to share melanoma insights and education with the community. We are excited to present this series during the month of April, and today we are launching our second session in educating and empowering the melanoma community. Throughout April, we will feature a variety of topics each Tuesday, and we are thrilled to engage today with our esteemed guest, Dr. Brent Moody, who will be discussing the importance of and the difference between familial genetics versus tumor genetics. Dr. Brent Moody completed his medical degree at Emory University School of Medicine. He completed a residency program in both internal medicine and dermatology at the Washington University School of Medicine Barnes Jewish Hospital, where he served as chief resident. In addition, he then went on to complete a comprehensive fellowship in Mohs micrographic and dermatologic surgery with Dr. George Haruza at the Laser and Dermatologic Surgery Center in St. Louis, Missouri. Dr. Moody is board certified in dermatology by the American Board of Dermatology and has been practicing in Nashville since 2003. Dr. Moody has served the local dermatology community as chairman of the Tennessee Dermatology Society and treasurer of the Nashville Dermatology Society. He is active on the national level as the chairman of the Public Policy Committee of the American College of Mohs Surgery. Before we get started, a little bit of background on the sponsorship behind this Ask the Expert series. Castle Biosciences is an innovator in diagnostic and prognostic tests for dermatologic cancer. Castle is a skin cancer diagnostics company providing personalized genomic information to improve cancer treatment decisions. Our team is focused on providing physicians and their patients with personalized, clinically actionable genomic information to make sure more accurate treatment decisions are able to be made. Castle currently offers tests for patients with cutaneous melanoma, along with cutaneous squamous cell carcinoma, suspicious pigmented lesions, and uveal melanoma, which is melanoma of the eye. Castle also has active research and development programs for tests in other dermatologic diseases with high clinical need. At Castle, we know that education is critical for patients making informed decisions about their care. This is why we have partnered with the Melanoma Research Foundation to host an Ask the Expert series, which will be touching on topics to help educate and empower the melanoma community. If you missed our previous session last week, which focused on the melanoma patient's journey with Dr. Abel Jarrell and one of his melanoma patients, it is available to view on the Melanoma Research Foundation's Facebook and YouTube pages, as well as Castle Biosciences YouTube page. Before we begin the presentation, please know that we encourage people to use the comment section to ask questions, which will be addressed at the end of today's presentation. The information presented during today's session is for educational purposes only, and any specific treatment-based questions should be directed to your healthcare provider. Now I am going to turn it over to Dr. Moody to share more about the difference between familial and tumor genetics.
Thank you, Liz. That's great. Really happy to be partnering with Castle Biosciences and the Melanoma Research Foundation to do this. When I'm counseling melanoma patients, I always want to know what are great resources for them. And certainly the Melanoma Research Foundation is one that I am happy to cite as a good source of reliable information. So I'm going to share my screen here momentarily. I don't have a whole lot of formal slides. I want to save a lot of time for questions, but let's get the slide shared. And so we should all be seeing a slide there. And this is where we're going to go, melanoma histology to genetics. Dr. Jarrell's presentation last week was very good. If you didn't see it, please watch the recorded version. And Dr. Jarrell is a dermatopathologist in addition to being a dermatologist, and did a really good job of going through some of the basics of melanoma, including some of the histology things that we look at in melanoma. And I would say that in many aspects of cancer, melanoma, of course, being one of them, we're understanding the power of genetics, and that for most of the time we've been treating cancer in sort of in modern medicine, it really was based on histology. That is, what did a pathologist see under the microscope? And that is still critically important and absolutely guides care. But what we're learning is that the genetics play a huge role as well. And as Liz said, there's the patient's genetics, which can influence things such as their propensity to develop a certain cancer, but then the genetics of the actual cancer itself, which determine how that particular cancer may behave. You probably, even in your own personal experience or your friends, know someone who had a certain type of cancer and they got treated and did fine. And you unfortunately know someone who had a very similar cancer, got treated and did not do well. And so we're still sorting out what accounts for the difference between, say, one melanoma patient and the next. So we've got a lot to learn, but we're definitely getting there. So let me get to my next slide. I'm in Nashville, Tennessee. We are best known for country music, of course, and this is the Ryman Auditorium, which is the first home of the Grand Ole Opry, and you can still come see shows there. So if you ever visit Nashville, I encourage you to check in to the Ryman Auditorium among our other great tourist activities. So when I'm thinking about, a patient with melanoma, or just a patient in general, we have to sort of think, well, what are the steps that we go through from the beginning of something on the skin to making treatment decisions? And step one is still a good history and physical examination. So seeing your dermatology provider is always step one. And as a clinician, when I'm seeing someone who I'm suspicious may have a skin cancer, melanoma, or any other skin cancer for that matter, there's certain things I want to be aware of. And number one, does the person have any skin spots or lesions that have changed? And that's where I really encourage patients to be engaged in their own healthcare, to pay attention to their own skin. If it's an area that they can't see, have a spouse or a friend or someone look at their back, look at their scalp, the areas that they can't see themselves. So being your own physician, as it were, doing your own physical examination is really important. Can't tell you how many times I've had a patient come and say, I'm worried about this spot. This spot has changed. It's started to bleed. This spot is new. So I really think that engaged patients and family are critical. So we have to pay attention to our own skin. Unfortunately, a lot of people will come to me and they have no idea about their skin because, we're busy. We've got other things going on in life than worry about our skin. So if you don't have all that information, it's okay. Still go see your doctor and let them take a look. And then on the family history side, really there's important things I want to know. Obviously, a family history of melanoma is important because if someone has relatives who have had melanoma, I'm starting to think, well, okay, could there be something genetic to this or not? And then if they've had a family history of pancreatic cancer, which we know in certain instances is associated with melanoma, that's something important. Other associated cancers, so mesotheliomas, meningiomas. And so I always encourage patients to find out a little bit about not only what mom and dad had, but what other blood relatives had, grandma and grandpa, aunts and uncles. Try to figure out what other people in the family had if you can. Obviously, the closer they are to you, the more pertinent it is. So mom and dad are much more important than cousin fourth removed. So you don't have to get too far along the family tree. And then there's this other really unusual type of nevus. It's not a cancer, but it's called a Spitz nevus. And so that's another thing that if you've ever been told you have one of those, you want to make sure you tell your a dermatologist about that. And then after that, it's really a head-to-toe exam. I tell patients, anywhere you have skin, you can have skin cancer. So expect a head-to-toe exam. I think most of the people in the Melanoma Research Foundation community, you have some personal experience with melanoma. So you understand what we talk about, the ABCDs. That is, is something asymmetric? Are the borders irregular? Has it changed? Is the color kind of off? Is it black, red, brown, a mix? The D is the diameter. How big is it? And then the other one we talked about earlier, has something changed, is some people say A, B, C, D, E, which evolution is something changed. And your doctor or your provider may use a thing called a dermatoscope, which you put on the skin. It sort of helps you look peer just under the skin almost. So there's kind of step one. That's just basic stuff we need to do. So other considerations with this increased melanoma risk, red hair and freckles seems to be something. Greater than 50 moles. So people with a lot of moles, particularly a lot of unusual looking moles, that's something we pay attention to. And then suppressed immune system. We know that increases the risk of melanoma. So there's some basics on melanoma. But let's transition to the topic of today, which is sort of genetics and familial genetics. This is a really common question. I'll get from someone who has melanoma. They want to say, well, is this genetic? Are my kids going to get this? Or the other way around is, my mom had melanoma. Does that mean I'm going to get melanoma? So for the vast majority of people, the answer is no. The vast majority of melanomas are not associated with a known genetic familial trait. And I say a known trait because we're still learning. And that's not to say in 5, 10, 15, 20 years, we might have different knowledge. But our understanding now is that the vast majority of people who have melanoma, it's just what we call sporadic. It just happened. To put it in a simple way, just bad luck, or you're one of those people that had fair skin and got a lot of sunburns or whatever. But it's not a genetic inherited tendency that you have. Only about maybe 10% of people who develop melanomas have one of these known genes. So again, it's not the majority at all. On the other hand, people who do have the gene do have a substantial chance of developing a melanoma. So it is something we think about. And so that raises the question, who might be a candidate for testing? Because clearly not everyone who shows up in my office with a melanoma should be tested for a genetic abnormality. And these are some guidelines that have been put forth of who might be a candidate for testing. If you've had several members on one side of your family who've had melanoma, that's why I said sometimes it's important to know, what your siblings, what your brothers and sisters have had, mom, and aunts and uncles. So multiple people in the family, you may be a candidate for testing. If you have a family member who's had multiple melanomas, so we do know that people who have these genetic traits have more than one melanoma many times. So if you've had someone who's had several melanomas, if someone's had both melanoma and pancreatic cancer, that's a hint that there may be a familial tendency here. We're going to talk a little bit more about that later. If you've had multiple melanomas, especially if you had the first one before the age of 45, that's something where you might be a candidate. And then remember we talked about that Spitz-Nevis business. If you've had 2 or more of these Spitz-Nevi, you might be a candidate for testing. Why did I say you might get tested? Rather than, oh, you meet the criteria, 100% you need to get tested. Well, we're not always 100% certain what we would do with that information. You meet the criteria to be tested. That is, if you have a family history of melanoma, or you've had melanoma, or anything, you should be really following safe sun practices anyway and getting checked anyway. I shouldn't have to do a genetic test on you if you've had melanoma to say, look, you need to be watching your skin and staying out of the sun. I mean, you should know that already. So how am I going to do it? Will getting a positive test change your behavior? Well, maybe. Back to my previous point, you know, I had one melanoma, maybe I just got unlucky, but if you have this family history and we test and you're positive, then I can say, you know, you've got a pretty good chance you're going to get another melanoma. We need to do these behavioral changes. And on the other hand, a negative test in a high-risk person, it's not a reason to have unsafe practices in the sun. So if you're a light-skinned person, red hair with freckles, just because for some reason you got tested was negative, doesn't mean you should go lay on the beach and bake. So hard to know what to do. And I put it in there because it is important. There sometimes can be negative insurance implications with having some of these tests. Well, some of the pros, you know, there are some reasons to think about being tested because as we mentioned earlier, there are other cancers involved. So pancreatic cancer is sort of the most typical one that we think of. It's involved with this gene called the CDKN2A gene. And so you can see sort of a list there of other cancers. So if you know you have this particular genetic issue, then it may be that you want to see specialists who deal with some of these other type cancers to be screened for them. So particularly, let's say you have the one they call BAP1, which is one we're learning about. Those people can get melanoma of the eye. And so if that's the case, when you see your optometrist or ophthalmologist, they would want to know that. So they pay close attention to the back of your eye. So these are just some things that might be helpful. I will say that guidelines on this are not really definitive. You know, when you look at the American Academy of Dermatology guidelines about who should or should not have a genetic test for melanoma, I'll just sort of read it here sort of directly so I get it correct. It says the ultimate decision to pursue genetic testing for mutations is a complex decision based on pedigree structure. That's a fancy way of saying your family tree. The cancer patterns and patient wishes. So, and it says that genetic counseling be considered if the criteria are met, that is those criteria I just showed you, and basically, and the person wants to be tested. So it says there's no strong evidence that genetic evaluation is harmful or helpful. Again, it's not 100% certain what you'll do with this information. So that's why the guidelines are still a little back and forth. This is kind of sort of how that works and what it looks like. If you happen to have a mutation, sort of a 50-50 chance you'll pass it on to one of your children. But if you do, it's an important thing. So you look at if you have this CDK2A mutation, which is kind of one of the first ones we discovered, and it's one of the more common ones, you can see that your risk of melanoma is substantially higher than the general population. And the same thing with pancreatic cancer. So again, that's something that you may want to know. People with the CDKN2A, they have lots of funny looking moles. So if you come to see me and your back looks like the person in panel A there, I'm already suspicious. I don't really even need to genetically test you necessarily because I'm already worried that you have a high risk of melanoma. This other one called BAP1 is very interesting because the people will get a lot of these moles that don't look that unusual. They don't look as funny looking as the one I just showed you, but they have some very specific histology findings under the microscope. So pathologists are now telling us, hey, this might be this particular type of nevus associated with BAP1. So it's something we're learning more about. Just a quick summary of why we pay attention, that the skin can be a a gateway to the rest of the body, some associated cancers for some of these in addition to melanoma. And you see the main one there at the top, pancreas. And then the BAP1 I talked to you about, renal cell carcinoma, some other melanomas. So there are some associations to be aware of. So here's again challenges with the risk profiling in this. Having traits can help us identify people at risk, but there are many people with the mutation who may never develop a problem. So sometimes you get this information and it can lead to almost like panic, like, oh my, I have this genetic mutation, now I'm doomed. Not necessarily. It can help with screening for some early detection of both the melanoma and other cancers, although I would say the guidelines are a little bit unclear on even the other cancers. So the one associated with pancreatic cancer. So screening for pancreatic cancer has been looked at. It's not clear that it really probably helps people live longer, but it's not 100% clear what to do with that. And then if you get tested, you may just get overscreened as well. So there's some downsides to that, some challenges with risk profiling. Now that's very different. Familial genetics, as we sort of transition to tumor genetics, I think tumor genetics are helpful in almost every case of melanoma. They can be helpful even before the diagnosis of melanoma is made. There are tests currently available that help pathologists determine that what they're looking at under the microscope is melanoma. And so frequently we'll do a biopsy, and the histopathologic or changes of melanoma under the microscope many times are clear-cut. Pathologists are certain. And then on the other hand, they're certain that something's a benign mole. Sometimes it can be difficult just based on what the pathologist is seeing to understand, is something melanoma or not melanoma? And so these tests can actually help the pathologist. So the genetics of that particular tumor can help the pathologist decide, is this melanoma or not? And then lastly, genetics can help with melanoma in helping me know what to do, how to treat an individual patient. So I find them very helpful in allowing me to assess an individual patient's risk of recurrence of their melanoma. So it can add to the information we already have. It adds to all of those things that Dr. Jarrell talked about last week, the Breslow thickness, which is important. Is it ulcerated? Those things the pathologists tell me, that helps me put a patient in a certain risk category, but then the genetics of the tumor by doing genetic expression profiling really helps me hone down to that individual patient. Individual tumor genetics, we talked about. It's about that individual person. We're not talking about groups anymore. We're not talking about population health. We're talking about personalized medicine. It can help figure out if you need a lymph node biopsy, and it can help to determine your individual risk of having a recurrence. And in my case, it helps me guide management decisions. I know that our speaker next week, Dr. Trotter, is really going to dive deep into this part of the genetics of melanoma, but I wanted to introduce it just to draw that distinction between sort of familial genetics, which gives you a propensity perhaps to get melanoma or does to get melanoma, versus the actual tumor genetics, which we know can influence your treatment course. So I've been talking now for almost 20 minutes. It's time for me to shut up and take some questions.
Thank you so much, Dr. Moody, for providing a detailed and thorough review of the difference between familial and tumor genetics, seeing as though there's a lot of new technology to differentiate the two, and really educating the community is where we start. We do have some really thoughtful questions that came in through the comment section. So without delaying that, I want to get through as many as we can and use your expertise to help clarify some things. So the first one, how often do you recommend visiting a dermatologist if I, one of the viewers, have one of these genes that were mentioned?
So that's a really good question, and there's not a great answer. It's not like we've studied. We do know that more frequent surveillance intuitively makes sense. And so I would base that on the sort of melanoma guidelines that the AAD has. So we know someone who has had melanoma, many times we recommend them being seen every 3 months or quarterly. And so in the case of someone who we believe has a propensity toward melanoma, but has not yet developed melanoma, certainly that would be a very thorough schedule. So you could do it every 3 months. On the other hand, if you're someone who has this propensity for melanoma, we know genetically, but for some reason doesn't have many moles to look at, might be able to spread that out some. So I would think in sort of that 2 to 4 times per year would be a good rough estimate on how often someone should be screened. And of course, the person should be really watching their own skin as well. And as I said earlier, get a spouse or someone you trust who will be willing to, look at your back that you can't see. I've had many times where hairdressers will detect a suspicious looking spot in someone's scalp and send them to the dermatologist. So if you have a hairdresser that you see and know, you could say, I've got this little tendency maybe to melanoma in my family. Do you see anything up there while they're doing your hair? So those are simple ways that can help when you have a propensity toward melanoma.
Thank you. I believe you and support all of the information to encourage patients to be as frequent and consistent as they can with their provider, especially with that risk on board. The second question, one viewer disclosed that they and their dad and their brother have all had melanoma, but tested negative for any of the genes that you had mentioned or known available genes to test. Is this a common result?
So it's one of the hazards of genetic testing. Number one is we probably don't know every gene associated with melanoma. So we know several, but that doesn't mean it's comprehensive. So there could be another particular gene that is responsible for the situation you described that we just don't know about. So that could be the answer. Or it could be that all three have what we call sporadic melanomas. So there is this other phenomenon that it's not really a gene mutation per se, we called shared risk factors. So if all three of the people in question are very fair-skinned, they're sort of Irish descent, that classic redhead, freckle, and they all lived in Key West, Florida, or they all went to tanning beds. So it could be that that shared risk factor is why they all developed melanoma. Another possible explanation. So those are kind of explanations why a test that you would expect maybe to be positive would be negative. And it's either we don't know what gene yet, or shared risk factor is actually the answer for why we're seeing this pattern of cancer in that family.
Thank you. And another question that came through, should parents get tested if their children are diagnosed with pediatric melanoma?
So that's another really great question. I would say if that they really don't meet those criteria I went through earlier, having one relative have melanoma doesn't really put you in that category. So I would think that probably would not necessarily mean that the parent needs to be tested.
And the next question, thank you for the last two. I can't expand on it at all. You're doing such a great job at really nicely answering these questions. Another one that came through is a little bit more broad and will answer probably a lot of questions for the viewers, that if melanoma does run in my family, should I have genetic counseling or visit a genetic counselor? And at what age would this be recommended to start?
Again, it would be if you meet those criteria that I showed earlier on the slide. You know, is it a family history of both melanoma and pancreatic cancer? Or is it multiple relatives who have melanoma? So, or if you have had multiple melanomas. So that would be sort of, again, if you meet the sort of well-recognized criteria for undergoing genetic counseling, then it would make sense. And as far as what age, I've not seen any data that says, oh, it's best to get tested at a particular age. I don't think that's ever really been looked at in a way that we can draw any conclusions. I would say certainly that you have the risk of melanoma, and we know that folks who have some of these mutations have an earlier onset of their melanomas. So usually, you know, before the age of 40, they may have their first melanoma. So I would say at any age, if you have this strong family history and you want to have genetic counseling, it would be appropriate to do it at any age.
So following with that, is there significant increased risk? And this is based on another question that came through, based on great grandparents, grandparents, or direct parents, and the risk associated with who's had it, and what that may look like as far as the patient is concerned in visiting their dermatologist.
Yeah, so the general guidelines, and it's not just for this particular cancer, but cancer in general, is the closer they are genetically related to you, the more significant that data is. So, you know, great-great-great-grandfather had melanoma is much less relevant than father had melanoma. So the closer the relatives are, the more important they are, which is what I sort of said earlier, you know, your sibling is more important than your cousin. So again, the closer you are, and that's where if you have a very strong history and you're concerned, sitting down with a geneticist who will really map this all out can be helpful.
Yes, thank you so much. So all of these questions have been very thoughtful and exciting to be able to address for the community. We are running out of time, but I do have one more question for you to round out the afternoon. In your experience, or can you add some color to how individual tumor biology has added benefit to you caring for your patients, even beyond what you know about their familial risk?
Oh yeah, absolutely. And that's sort of, I'm glad that's our last question, because it'll be a little teaser for, I think, what Dr. Trotter is going to talk about next week. So one of the difficulties as someone who treats melanoma is as someone comes to see me, they have melanoma and we'll treat their melanoma. Let's say we get it treated. What do we do going forward? You know, what is that person's risk of the tumor coming back or the tumor spreading to another part of the body? And so when we just base our understanding of that on histology, that is what the pathologist sees under the microscope, we get sort of broad categories of patients. So you will be a stage 1, say, based on that. And we know that many, many patients with stage 1 do really, really well, right? They never have a further problem with their melanoma. But there are some patients who are stage 1 and early stage of melanoma who will have a problem. And so it helps me as their physician to do the genetic test and determine, okay, unfortunately, according to the genetics of your melanoma, you are someone that has a greater likelihood of having a problem in the future. That is, that comes back or it spreads. So as a result, I'm going to see you more frequently. Maybe I'm even going to want to do some imaging, some radiographic imaging. So I'm going to treat that person with a high risk genetic melanoma profile a little more, I don't want to say thoroughly, but more aggressively. I'm going to see them more frequently. I'm going to do more than if someone comes back with a very low risk genetic profile. Then we can sort of back off and say, okay, the likelihood that your tumor is going to come back or spread is very low. Let's sort of dial down what we're going to have to do for you. So it allows me to, within a certain stage of melanoma, treat people really based on their risk rather than the population risk, as it were.
Excellent discussion. Thank you so much. This concludes our second Ask the Expert series session presented by Castle Biosciences. These sessions will live on the Melanoma Research Foundation's YouTube and Facebook pages, as well as Castle Biosciences YouTube. If you're looking for more resources, please visit the Melanoma Research Foundation's educational resource page at melanoma.org. And thank you so much, Dr. Moody, for your thorough explanation and Q&A session. I found it to be very helpful myself.
You're very welcome. Thank you.
And for teeing up next week. So our third Ask the Expert session is next week, Tuesday, April 20th at 4 p.m. Eastern, 1 p.m. Pacific, right here on Facebook Live. In the next session, we will hear a presentation, as Dr. Moody alluded to, from Dr. Shannon Trotter, Assistant Clinical Professor at Ohio University Heritage College of Osteopathic Medicine and a dermatologist at Ohio Health Physician Group. Dr. Trotter will be discussing the use of gene expression profiling, specifically in melanoma risk assessment. So a deep dive beyond the last little bit of Q&A that we had with Dr. Moody this afternoon. And again, on behalf of Castle Biosciences, we thank you, Dr. Moody, for your time, presentation, and expertise. And we are greatly appreciative of all you continue to do for the melanoma community. And thank you again to the Melanoma Research Foundation for your collaboration on this series and all you do to support the melanoma community. Thank you to all of our viewers for this afternoon's presentation, and we hope to see you all again next week. Take care.